Good afternoon, everyone. My name is Jennifer Deneen. I'm a faculty member in the Department of Public Policy, and I co-direct, along with Professors Carrie Raytheon and Mary Bernstein, InCHIP's Gun Violence Prevention Research Interest Group. It is my sincere pleasure to welcome you to the InCHIP Lecture Series talk, Addressing Firearm Injury as a Public Health Problem, and introduce our speaker, Dr. Megan Ranney. Dr. Ranney is an emergency physician, researcher, and national advocate for innovative approaches to public health. She holds the Warren Albert Endowed Associate Professor of Emergency Medicine at the Albert Medical School of Brown University and is founding director of the Brown Lifespan Center for Digital Health. She is also the Associate Dean of Strategy and Innovation at Brown School of Public Health. Dr. Ranney's research focus is on developing, testing, and disseminating digital health interventions to prevent violence and mental illness. She has had continuous external funding from federal and foundation grants for over a decade, with more than 120 peer-reviewed publications. She serves multiple national leadership roles, including Chief Research Officer of Affirm Research, the country's leading nonprofit committed to ending gun violence epidemic through a nonpartisan public health approach, and president of the board of GetUsPPE.org, a nonprofit that is delivering donated personal protective equipment to those who need it most. She's the editor for the Annals of Emergency Medicine, a fellow of the fifth class of the Aspen Institute's Health Innovators Fellowship Program, and a member of the Aspen Global Leadership Network. Dr. Ranney earned her bachelor's degree in history of science, graduating summa cum laude from Harvard University, her medical doctorate graduating Alpha Omega Alpha from Columbia University, and her master's in public health from Brown University. She completed her residency in emergency medicine and a fellowship in injury prevention research at Brown University. Dr. Ranney has been working for more than a decade applying a public health framework to the gun violence epidemic through her scholarly publications, her public scholarship, and by harnessing the power of social media to demonstrate that gun violence affects all Americans. She is a frequent media commentator on outlets ranging from CNN to The Atlantic to the New York Times, and an active voice on Twitter. In 2018, she started #ThisIsOurLane to raise awareness around the roles physicians occupy in the gun violence epidemic, including treatment, prevention, and victim. She has received numerous awards for technology innovation, public health, and research, including Rhode Island Woman of the Year and the American College of Emergency Physicians Policy Pioneer Award. Dr. Ranney, welcome. We are very, very glad to have you with us today.
Thank you. It is an absolute honor to join you, Dr. Deneen, and to join all of you. I just wish that it could be in person. And for those who joined right at the beginning, I was kind of frantically switching slides around as we were chatting. I could be giving this talk from any of a number of perspectives, as Dr. Deneen just outlined. But what I'm going to try to do is to take us through just kind of the general outline of the ways in which I think about it's important to address firearm injury as a public health problem and where I see their future going forward. I'm not going to talk a lot about my own research, partly because so much of it is new, which we'll talk about as we go through. But really excited to be here with all of you today. Let's see, the joy of, there we go. So disclosures, right? So I have NIH and CDC support. I do serve on them as roles within 2 nonprofits, both volunteer, and I do have unrelated funding from Medscape. I also, as a good academician, want to give acknowledgments to 2 of my closest collaborators, Dr. Emmy Betts, who's at University of Colorado, and Dr. Garen Wintemute at UC Davis, with whom I developed some original versions of this talk and have co-delivered parts of this talk in the past. They're also just part of my team. And I think if you take anything away from this talk, it's that to make progress in the world, you need team science and you need collaboration, and they're part of my team. So I'm going to start with a story. A little over a decade ago, I was a relatively new attending physician at my hospital. And I was working in our trauma rooms on a Saturday night in July. At that point, Providence was full of gun violence. There was not a weekend night that went by without at least one, usually multiple shootings. And we kind of expected that the quote unquote knife and gun club was going to show up. I had brand new residents because it was early in the year and kind of residency transitions over in July. So I was prepping them to the way that traumas work, the way that our critical care system works. And we got a call over EMS saying that they were coming in with a GSW, a gunshot wound. So we prepped our trauma rooms. We got my team. I got my trauma surgery team. We had our respiratory therapist, our social worker, all the med students crowded in. Everyone thought that they were going to get to do some procedures, and there was this little bit of excitement in the air, which is part of emergency medicine. We love the time-sensitive conditions. And then the ambulance rolls up. We're Rhode Island. It's small. Didn't take very long for them to get there. And they come in the door and wheel into the room. And there was this look on the EMS providers' faces. And we look at the stretcher, and they start to tell us the story. And we look at the guy, and the air kind of goes out of the room. And the reason why was because this young man was not the GSW we thought we were preparing for. It wasn't a victim of community violence. It was a young man who had shot himself in the head and was still barely alive. As the story turned out, he'd shot himself with his father's gun. The father was part of our local first responder community. So the guys that brought this kid in knew the father. And the gunshot wound was so clearly a non-survivable traumatic injury, as so many gunshot wounds are. But this was different from what most of us in the room had ever seen. We kept the kid alive long enough for the dad to come and say goodbye. And that moment stuck with me for a lot of reasons and has shaped much of what I've done around firearm injury ever since. It actually is one of the events among many in my clinical care that motivated me to start speaking up. And it stuck with me and changed my perspective for a few reasons. The first is that was the first time I'd ever seen someone try to take their own life with a gun. As I'll talk about later, it turns out that suicide with a gun is just tremendously common. But we rarely see them in the emergency department because they rarely survive to get to us. That incident made me start questioning why we don't see it, what's different about suicide with a gun from other types of suicide attempts, and why we weren't doing more to prevent it. The second thing about that incident that stuck with me was the change in the tone of the room. And it really highlighted the degree to which structural racism plays into our response to firearm injury. I had already by that point been trying to do research on community violence and had been told over again, it's hopeless, there's no point, it's not fundable, it's not changeable. And part of that, honestly, is about the race of who gets injured. And I'll talk about that later as well. But that incident, that young kid that we took care of, really brought into stark relief the degree to which structural racism affects our response to firearm injury. And the third thing that I carried with me and continue to this day was the effect on the dad, on the larger EMS community, and on the larger community in general. And I think of it every time I take care of someone with a gunshot wound, it's that it's not just about that patient, but it's also about the ripple effect. And the reality is that for all of us across the United States, we are going to interact with someone who has been a victim of firearm injury. Firearm mortality is not equal. Firearm mortality rates are not equal across the U.S. The states with the highest rates of gun death are actually maybe not what you'd predict. It's many of our more rural states: Alaska, Missouri, South Dakota, Montana, Louisiana. But in every state across the country, there are gun deaths and gun injuries. And realistically, most of us, even those of us that come from an upper middle class background or who work in academia, are going to know someone who has been affected. If you have a family member who's in the military or who is in law enforcement, our military and our vets have an order of magnitude higher rate of firearm death and firearm suicide than the average population. Healthcare workers are also more likely to kill themselves with a gun. Young minority men and women are more likely to know someone who has been shot and killed. Many of us know someone who has been a victim of domestic gun violence, who has either lost their life or been threatened. And of course, there's firearm suicide, which I'll talk about. And so as I go through this talk, I do want to acknowledge that this can be a very personal issue for most of us. But that incident also points to the fact that there is a different solution. And I am an ER doc, but I'm also a public health professional. And the perspective that I want to share with you today is that we can move by using the public health approach from this same tired debate that we've been having as a country for the last 20 or 30 years around this debate between kind of policy of gun control, politics of gun rights, right? It's presented as this very oppositional tension, and instead talk about the problem, which is that people are getting shot, are getting hurt, and are dying, and that there is a solution, which is the public health approach. And I'll take us through that today. So briefly, kind of an overview of what I'm going to talk about. I'm going to start by centering us all on the numbers, a very brief overview of the epidemiology. Second, I'll present a little bit about that public health framework for action, specifically centered on injury prevention. And third, I'm going to talk about things that we can do using that health or public health centric approach, both in the clinical setting and then outside of the clinical setting. And I know, talking to Jennifer and Amy beforehand, that most of your work is kind of more in the policy or the outside of the healthcare setting, but my hope is to present a little of both to you today. So let's start with the numbers, the epidemiology of firearm deaths in the United States. So who's dying? To orient you, this graph, the x-axis is age groups in 5-year increments. The y-axis is absolute numbers. This is 2018 statistics, which are the most recent available in whiskers. So here is the pattern of deaths among men versus women. You'll see there's a spike in the young adult years for men, and then it kind of flattens out up through middle age. For women, deaths go up in the young adult years and then stay flat, really kind of right through until older year, the kind of, you get into the elderly or kind of geriatric years. And I'm going to dive deeper into the male deaths. But let me say for women, the majority of gun deaths among women are domestic violence. More than half of them are domestic violence homicides. It's part of the reason why it's so stable across the life cycle, is that we're all victims of domestic violence, no matter how old we are. But as with most injury patterns, 85% of gun deaths are men. Let me talk more about men. Let's talk about the race and ethnicity. Again, x-axis is age groups, y-axis is absolute numbers. This is the pattern of death among non-Hispanic whites. You see, again, it goes up. There's not a lot of deaths in the young ages, goes up dramatically by around age 15, stays high. And then for white men, you get this new peak kind of in middle age, kind of going into the geriatric, going into kind of age 65 plus. We see a very different pattern of gun deaths for non-Hispanic Blacks and Hispanic men. And what this graph, to me, really the takeaway from this kind of view of the patterns of gun deaths is that there are in many ways two epidemics. The first is one that disproportionately affects young minority men. That is primarily gun homicide, but so disproportionately affects young minority men, but certainly young white men are also affected. And the second is gun suicide, which disproportionately affects white men, particularly middle-aged white men, but we're seeing increasing rates of gun suicide among Black and Hispanic men as well. Overall, 2/3 of gun deaths in this country are non-Hispanic whites. And I think that's a really important statistic to know, because as Jennifer and I were talking earlier, one of the big things when I think about that public health approach and transitioning from this policy or political debate into a talk about health is making folks feel that no matter who they are, they too are both at risk, and they and their families and their community are being affected by firearm injury. And so I find that when I talk about firearm injury in larger groups, the fact that 2/3 of gun deaths are non-Hispanic whites is something that often shocks people, and for better or for worse. And I talked about the structural racism aspects to our approach to this, but makes them sit up and pay attention. Let's talk about why they die. So in injury prevention, any of you that work in injury know that we talk a lot about kind of E-codes, or we talk about the intent of an injury. And I think that's a really important thing to dive into here, because there is this preconception in the United States that firearm injury and firearm death is all about homicides and mass shootings. The reality is very different. In 2018, there were approximately 40,000 gun deaths. The rate was approximately 12 per 100,000, which is where it's been for the past few years. Of those, only about 1% were quote unquote accidental. Injury prevention folks don't talk about accidents. We say it's unintentional. These are things like a kid finding their firearm in their parents' nightstand or hidden underneath the seat of the car and accidentally shooting themselves, a family member, or a friend. Tragic incidences that should never happen. And I know you guys are working on safe storage. That's the best prevention strategy for this, but they are, thank God, relatively rare. Only about 0.3% of deaths in a given year are public mass shootings. And the definition of mass shooting is, depending on what you read, is going to be a little bit under debate, how many people, where it happens. But here I'm using the term that most of the public thinks about, which are these public things like Aurora or Sandy Hook, workplace violence incidents where more than 4 people are shot at a time. They are, again, horrific events that capture the national consciousness, but are tremendously rare. Around 36% of shootings, gunshot deaths in any given year are homicide and legal intervention. I collapse these together because they're tremendously difficult to disentangle right now with the current data sources. There's obviously been a lot of attention appropriately over the past year to law enforcement officer involved shooting deaths. But for now, I'm gonna categorize them together. The important takeaway here is it's only about 1/3 of gun deaths are homicide. That includes domestic violence also. That is stable year after year after year. This is not the dominant reason for people dying of guns in the United States. The dominant reason is suicide. It's consistently about 2/3 of gun deaths are suicide in the US. And again, I presented that graph about kind of the age and the race and ethnicity differences. But if you take kind of a second thing away from my talk, it will be this. Now, I just talked a lot about deaths. I didn't talk a lot about injuries. The reason why is that our data on injuries is tremendously unstable. And if we have time at the end, we can talk a little bit about it. But I do want to mention something specifically about peds. So firearm injury is the second leading cause of death for American youth. And the perception, again, is that this is about mass shootings. But this chart was created by a friend of mine after Parkland. It shows, excluding suicides, firearm injuries and death sustained by American children in the first 50 days of 2018. The bright greens are school shootings. The light blues are cumulative injuries. Dark blues are daily. Light pinks are cumulative deaths. Bright are daily deaths. And what this shows is that there's about a 2-to-1 rate of injury to death among our American youth. And again, those school shootings are so uncommon, but our kids are being exposed to this every single day across the United States. Finally, when we talk about numbers in epidemiology, I think it's really important to mention the number of guns versus the number of deaths. I do a lot of work with firearm owners, both people who own firearms legally and people who own firearms illegally. There are about 330 million manufactured guns in circulation in the United States. That's actually gone up significantly during COVID. But there's also a lot of guns that we actually don't know about. There are ghost guns that are kind of manufactured at home, 3D printed guns as well. Even with that, so the 330 million is an absolute underestimate. Nonetheless, there were only about 40,000 gun deaths. Now, 40,000 is far too many, but the point here, and something that I think is important for those of us that are trying to bridge these political divides, is that the vast majority of guns in the United States are not used to hurt or kill someone. So one of our key tasks is to think about what's the difference. And it's not that guns are a benign tool. They certainly have the potential to maim and to kill, but not every gun is used to hurt someone. So with that as background, kind of some shared facts, which I think are all too important in this moment of political divide, let's move on to talking about the framework for action, the public health model, and the kind of concept of the 3 E's from injury prevention. So you guys know this backwards and forwards. I don't have to spend a lot of time on it. Our basic public health approach, right, is 4 steps. First is surveillance, a word that I don't use when I'm talking kind of with non-public health groups because it creates this sense of big brother, but the idea of kind of getting data, right? What's the scope of the problem? Second is to identify risk and protective or promotive factors. So what determines who's likely to die and who's likely not to? If you otherwise, all things being equal, what protects someone who you might think is high risk? And something important here is that we've traditionally, of course, talked about race and ethnicity as being a risk factor. I now think of it as being a risk marker. It's not that someone who is Black is inherently at higher risk. It's about the structure around them, right, that puts them at risk. But this is the second step in doing good public health. Once you've done that, you then develop and evaluate interventions. And the evaluation is critical, right? What works and for whom? How do you tailor it? How do you make it more effective? And so within injury prevention, when we're talking about interventions, we usually talk about there being really 3 E's. The first category of intervention is education. The second is enforcement and enactment, policies and their appropriate use. And the third is engineering. All 3 of these are critical to effective injury prevention interventions. I'll use the example of cars, right? So for cars, we have drunk driving laws and enforcement of them. We have education about drunk driving, and we have changes in engineering, such as putting an ignition lock or doing things like having an Uber available that allows you to kind of avoid drunk driving. I could make similar parallels around graduated driver's licensing, around seat belts, et cetera, that you need a combo of all 3 types of interventions to effectively decrease injuries. And would argue the same is true for firearm injury, and I'll take us through that. So then, of course, the last step in public health: surveillance, risk and protective factors, develop and evaluate interventions, and then we implement. And ideally, we don't implement until we already know what works, which is where we've been stuck in firearm injury for the past 2 decades. We have no idea what works and for whom, outside of some very rough and non-specific policy interventions, which are inconsistently passed, inconsistently applied, inconsistently enforced, and which have rarely over the last 2 decades been accompanied by those other E's. Now, when we apply this 4-step public health approach, I don't need to tell you guys, but it works. This graph, we have age along the x-axis and rate per 100,000 along the y-axis. I include rate rather than absolute numbers because, of course, our population changes over time. This is our pattern of car crash deaths in the US. We had a peak in the late 60s, early 70s. We've since decreased our rate of car crash deaths by approximately 70%, not by taking cars off the road, but rather by putting those 3 E's in place, by educating, by enforcing, and by engineering. Similarly, that 4-step public health approach has worked for infectious diseases. And I actually need to update this now for COVID, which is another example of a great similar problem. Are the slides not changing for you guys? I can see Colleen. Colleen, are the slides changing for you? Yes. Okay. I saw a comment come up. Good. The second is HIV/AIDS didn't really exist, or we didn't know about it until the early 80s. Death rates spiked to about 15 per 100,000 by the mid-90s. We've since decreased death rates by more than 90%, again, not by banning sex or banning drugs, but rather by using good science and that 4-step public health approach to develop education, to develop scientific kind of interventions, PrEP, heart, et cetera, and also a little bit of policy change. But we know that with HIV/AIDS, this is not about condemning behaviors, but rather about looking at risk and protective factors, reducing risk, enhancing protection. Now compare that to firearms. We had a spike in the rate of firearm deaths in the 80s and 90s, where we were at about a 15 per 100,000. That was largely due to the crack epidemic. Rates decreased substantially in the late 90s to a low of about 10 per 100,000. But over the last 10 years, rates have been inexorably creeping up to the point now where the rate of firearm death is actually higher than the rate of car crash death in the United States. And I would argue that a big part of the reason why is not just political divides, not just kind of the fact that there are a lot of guns out there in circulation, but also it's about the lack of the application of the public health approach. Because there are actually more cars on the road than there ever were, and there are more millions of miles driven than ever before, and yet our car crash death rate has stayed persistently low. So I think simply blaming it on the number of guns is much too easy of an explanation. Now, why do I think we haven't applied it? This is one of my favorite graphs that I put in almost every talk I do. This came from an article in JAMA a few years back, where the authors pulled out of NIH Reporter all of the federally funded research, NIH, NIJ, and CDC, for the dominant causes of death in the United States, and did a regression analysis comparing the funding in US billions to the mortality rate. This graph is shown on a logarithmic scale, but as any of us kind of wouldn't recognize, the light gray is that 95% confidence interval, and you see that for the vast majority of diseases and injuries, the amount of funding is essentially proportional to the mortality rate. Gun violence, of course, completely falls off this graph. It received only 1.6% of predicted funding from 2004 to 2015. I'll say other types of injuries, falls and drowning, also are disproportionately low, and we can talk about that separately. But the lack of funding for firearm injury is just a travesty and explains part of the reason why we've made so little progress. This past year, NIH and CDC did get a $25 million appropriation from Congress for the first time since the Dickey Amendment was passed in 1996. That's only 25 million. You can see, so we've doubled the amount that was spent in the last decade, but it's still far less than what would be predicted based off of the mortality burden, which is $1.4 billion. And I'll compare it to the amount that we spend on sepsis, which is a disease that kills a similar number of people in the United States per year. Now, I mentioned the Dickey Amendment. For those who aren't familiar with it, Jay Dickey was a junior representative from Arkansas who passed the infamous Dickey Amendment in 1996 in response to some research done by a fellow emergency physician, Art Kellerman, showing that having a gun in the home increased your risk of gun death. Seems like a really basic study for any of us who do public health. Owning a car increases your risk of car death, right? Having a pool increases your risk of pool death. It's the first question. The next question is, how do you prevent it? But Jay Dickey took this, as did many others, as being an infringement on rights of firearm owners. Passed this Dickey Amendment, which took basically, it said that you couldn't use federal funds for advocacy around firearm injury prevention. But at the same time that they passed this amendment, they took all the money away from the CDC that they had been spending on firearm injury prevention and gave no appropriations to the CDC from 1996 until 2020. Basically shut down and froze firearm injury prevention research for 2 decades. Jay Dickey, after Sandy Hook and after some of us had been kind of starting to raise our voices about the importance of this public health approach, he himself recognized that research, again, is not inherently either about policy or about gun rights. Rather, research could have been continued on gun violence or firearm injury without infringing on the rights of gun owners in the same fashion that the highway industry continued its research without eliminating the automobile. He then said, "It's my position that somehow or some way we should slowly but methodically fund such research until a solution is reached." We've started to do that, but we still have a long ways to go. All right, so that's the framework for action and the numbers. Now, in the next 15 minutes or so, I'm going to take us through very rapid fire, no pun intended, through some actions and ways that we can apply this public health approach, both in the clinical and the non-clinical setting, with the hope of spurring thought and discussion among you guys and hopefully coming back at a later point. So traditionally, over the last 20 years, we have approached firearm injury using the medical model, or kind of, again, using that very kind of policy-based approach rather than taking the public health approach. We have focused entirely on resuscitation after a shooting happens, trying to stop mortality from that shooting, rather than talking about what happens upstream. Unfortunately, resuscitation doesn't work super well. This is a study from Colorado showing that the case fatality rate for gunshot wounds is increasing. It's not because we're not doing a good job as trauma surgeons and ER docs. It's because the types of guns are changing and the number of gunshot wounds that an individual person is sustaining is increasing. It's different from every other type of injury where we overall are seeing a decrease in case fatality rate. So resuscitation doesn't work. And it also doesn't work for suicide. So this graph is largely around homicide, but it also doesn't work for suicide. We know that overall, only about 10% of people with suicidal thoughts or actions die, but 90% of people who use a gun to try to kill themselves do die. And that is a totally preventable number, especially given that that final decision to act is often impulsive. And when I think back to the story I started my talk with about that young kid who shot and killed himself, if he had not been able to access his father's gun, if he had come into my emergency department after taking an overdose of Tylenol or ibuprofen or doing any of 1,000 other things that people do that I see them for every day in the emergency department, we probably could have saved him. And if we had saved him, he probably would have gone on and lived a perfectly normal life, because most people who survive a first suicide attempt do go on to die of natural causes and live out their life normally. So approaching only from the resuscitation approach doesn't work. Inherent to this public health approach, that 4-step, is the idea that we can intervene earlier. And when I talk to medical audiences, I talk about us doing an intervention at the time of an escalation of risk factor, right? We can talk about primary or secondary or tertiary prevention. I think that where firearm injury lies right now in our country, it is ripe for secondary prevention, or for kind of late primary for folks that have some sort of indication, not universal necessarily, but some sort of an escalation of a risk factor. We can do that effectively. Of course, the ideal is that we can stop the shootings, stop the need for a resuscitation, and then stop all of those downstream ripple effects, which I alluded to early on in the talk, for future shootings, post-traumatic stress, retaliations, the effects on communities, on doctors, on pre-medical, pre-hospital providers, and on our nurses. So what is it that we can do within and outside of the healthcare system? So within the healthcare system, we can think about risk factors the same way that we think about them for every other disease and injury pattern. And right now, for firearm injury, we know of a few rough predictors of who is at risk that I tell my medical colleagues to concentrate on, given limited time and political will behind interventions. The first, obviously, is folks who are at risk for suicide. So people that are depressed, have a history of prior suicide attempts, have other risk factors for suicide. Those are folks that deserve to be particularly screened for firearm access and have an intervention delivered to them. The second is folks that have a history of physical fights. We know that if someone has been in a physical fight, it triples their risk of future firearm injury. We know that if someone has been shot and survived once, they're at 300 times the risk of future firearm injury and death. So it's a major risk factor for firearm injury and deserves specific screening and intervention. The third major risk category for those of us working in the medical world, and for those of you working in public health who want to work with us in healthcare, is domestic violence. For any of you that work in the field of intimate partner violence, you know that Jacqueline Campbell's famous danger assessment, the partner's access to a firearm or having previously been threatened to a firearm increases your risk dramatically, and is one of our biggest predictors of death. It also makes the moment of leaving, of course, much more dangerous. There are also some other growing indicators of risk, which the evidence is still developing on. The first is a history of substance or alcohol misuse. That relates, of course, into suicide, into homicide, into impulsivity in general. Garen Wintemute has done some studies showing that people who have been arrested for DUI have a significantly higher risk of both firearm homicide and firearm suicide going forwards. I think we're going to see more around this going forwards. Next is dementia or cognitive decline. I'm working with Dr. Betts on work specifically with this older American population. We know that older folks own or have access to firearms at similar rates to the rest of us. We know that the moment of diagnosis of impending dementia is a moment of higher suicide risk. And we also know that folks that have dementia or cognitive decline are likely to have paranoia, behavioral disturbances, et cetera, that make owning that firearm more risky, not just for them, but for their family members and caregivers. There was just a story the other day, yet again, about a man with mild dementia who shot a caregiver. And the third category here that kind of around evidence is around kids. A lot of us concentrate on little kids and that accidental injury, right? Or unintentional injury, around the importance of safe storage, just like you have, you put your poison, you take your poisons out from under your sink and put them somewhere safe, the same way that you put kids in car seats. But when I talk about kids, I really want to emphasize that it's not just kids, but it's also adolescents who are at dramatically increased risk of firearm suicide and homicide as well. And so that requires a little more digging in than we have time to do in this hour. And of course, all those groups that I just mentioned, folks that are at risk of suicide or folks that are depressed, people with a history of partner violence, people with physical fights, and then patients with cognitive decline, et cetera, all have access to firearms. So the rate of firearm ownership among all of those risk groups is approximately the same as in the general population. There's not a lot of diseases out there where if I tell someone that the rate of the kind of potentially lethal factors as high as 30% among a risk group. So these are risk groups that have high access to firearms. So what do you do kind of within the healthcare setting? The best evidence that we have right now is really kind of this SBIRT model: screen, intervene, and then refer if it's more than you can do in a one-on-one interaction. Another analogy that I frequently use is that it's the harm reduction framework, which many of us that work in substance use are quite familiar with. It's the idea that, if someone's drinking and driving, you don't tell them, I'm going to take away your car forever, assuming they haven't had multiple DUI convictions. It's, I'm going to take your keys for the night, right? It's the same idea with substance use. You provide people with safer ways to use substances. And a lot of the work that I'm doing, and that I know that you guys are doing as well, and that I think is really going to become dominant around firearm injury prevention across the country, given the reality of the number of guns that are out there in circulation, we cannot take an absolutist approach. We have to take this harm reduction approach, which is about trying to take people from this level of risk down to this level of risk, and then we can try to decrease thereafter. When I'm having these discussions with patients or telling my colleagues to have these discussions, the language really matters. It's not about giving up, disposing of, or relinquishing your guns, but it's rather about talking in terms that allow the patient to buy in, using that motivational intervention framework and focusing on the hopefully temporary nature of both risk and relocation of guns. There will, of course, be some patients whose risk is too high, and we can talk separately about policies, the quote-unquote red flag or extreme risk protection orders. But for the majority of folks, this harm reduction approach will work and has been shown to make a difference. And there's been 24 years of limited research. There's a lot going on right now on this topic, but which doesn't yet have reliable results. But there are publications showing that brief counseling and a trigger lock in a pediatric environment can increase use of safe storage by families. Emergency department and trauma service interventions can decrease the risk of future fights and weapon carriage. There's a bunch of studies ongoing right now about their efficacy on firearm injury. And then there's a bunch of studies, as any of you that work in suicide know, around the importance of lethal means counseling, showing that it works for adults, but also for teens. And there's some exciting research that's ongoing about how to do that more effectively and in a more culturally competent way. Now, I'm frequently asked when I talk about this part of firearm injury prevention, well, are you allowed to talk about guns? There is still this prevailing myth that we are not, but I want to be super clear. There are no laws in the United States that prohibit physicians or other healthcare professionals from talking to patients about firearm ownership. There was a transient, horrible law in Florida, the so-called Docs versus Glocks law, that limited our ability to talk to patients, but it was very quickly overturned as unconstitutional and has not been passed in any other state since. So there are no federal or state regulations stopping us from talking. There are, of course, a bunch of other barriers, though, which any of us working in health behavior change and physician behavior change know about: time, knowledge, resources, comfort, and there are a lot of us working on ways to address those. And I'm happy to talk about those in Q&A. So that's kind of the healthcare perspective on how we can apply that public health approach, take what we know about public health in other settings and apply it to firearm injury, right? SBIRT or motivational interviewing, harm reduction, et cetera. Now let's talk about the other side of stuff. What can we do externally to the healthcare setting? Here, it's really about collaboration, cooperation, and removal of barriers. I'm going to say again, I do not think that this is entirely about, and I admire the folks that are doing peer advocacy. I, first of all, can't because I do have federal funding and that Dickey Amendment still is in place. But also, I think that it's not really the sole solution. There is, again, no injury in which passing laws alone fixes it. We also need those other E's. And so when we think about doing kind of interventions external to the health setting, I want to acknowledge that what those interventions are going to consist of is going to depend on where you are and who you are. There are tremendously local patterns of firearm injury and death. This is a county by county map across the United States. And you see that there are different patterns, rural versus urban. Are you in an area where hunting is really important? What's the partisanship in your area? What are your laws? They're all going to influence the type of interventions you design. But no matter who you are or where you are, collaboration is possible. And one great example is the collaboration between the National Shooting Sports Foundation, which is a trade organization of kind of firearm sellers, and the American Foundation for Suicide Prevention to teach gun shops about risk factors for suicide and basically doing some basic gatekeeper training. There's preliminary evidence that it increases fire or gun shop owners' comfort with suicide prevention. Full data is still pending. But there's actually a number of these coalitions that have sprung up across the country, suicide prevention partnerships with gun owner groups. And there's some more recent work where it's moving beyond suicide prevention. And I highlight Emmy Betts's Colorado Coalition for Firearm Safety here, where we're also talking about domestic violence, pediatric injury, et cetera. To me, this is one of the true ways forward for us as a country, is again, moving past that gun rights versus gun control debate and creating safe spaces for us to have these conversations and move into the harm reduction framework. Another thing that you can do external to the healthcare system are violence intervention programs. I talked about, right, that expert model, the referral to treatment. Folks that are injured in an assault, particularly by a gunshot wound, often have a complex set of concerns and issues, and the prevention of future firearm injury can be complicated and maybe more than we can ask a provider to do in an individual patient visit. And there's some preliminary evidence that a single intervention, or some of the work that I'm doing is a single intervention plus text messaging, may be protective, but there are also more complex treatments to develop. The hobby is the Health Alliance for Violence Intervention, which is a group of violence intervention programs across the United States. There are other similar community-based groups such as Ceasefire. I'm on the board of our local Institute for the Study and Practice of Nonviolence in Rhode Island, which is not hospital-based, but has a similar kind of peer support, street worker focus on stopping the cycle of retaliatory violence. Many of these groups address mental health problems, some substance use problems, criminal justice issues, help people get an education, get a job, et cetera. And there's some preliminary evidence of effect of these types of programs. Another type of intervention, I said, I'm not going to talk a lot about policy, but there is an intersection between policy and healthcare. I've worked with the Massachusetts Attorney General's office, and I'm working with the American Medical Association to clarify the implications of policy for physicians and other healthcare providers on how we screen, what we record, and what we can do if we think a patient is high risk. Whether it's an extreme risk protection order, whether it's knowing how they can do temporary transfer of a firearm to someone else if they're suicidal. I'll give an example of where this is super relevant. I took care of a police officer a few months back in my emergency department who was there because he was feeling really depressed and was having occasional passive suicidal thoughts. And because I knew this data, I was able to provide some solutions about how he could temporarily store his firearm safely until we got him into treatment. He didn't meet criteria for hospitalization, but I was super uncomfortable with sending him home, knowing that he could access his service weapon at any point. And so we figured out a solution for him based off of my state's laws that was safe and legal, and that protected his job and protected himself and his family. And so this type of kind of conversation around policy can be really important. And then, of course, there's the larger picture stuff, the advocacy, which Dr. Deneen mentioned a little at the beginning, and which is really one of my passions in life, is how do we take these sticky issues and bring them up into public consciousness and move the public forwards. After Sandy Hook, there was a spate of publications about firearm injury being a public health problem. We then created a lot of research agendas over the next few years, from the Institute of Medicine, now the National Academy, from individual organizations, my own American College of Emergency Physicians, from Kaiser Permanente, American College of Surgeons, the FACTS Consortium, which is a large group of folks committed to research on firearm injury among children and teens based out of University of Michigan. And we've worked together to kind of try to create this research agenda so that people know where to move forwards. For those interested in doing this research, I recommend that you look at any of these research agendas. And then we've created larger coalitions. And I mentioned that I'm the co-founder of a group called Affirm, or the American Foundation for Firearm Injury Reduction in Medicine. We're dedicated to a nonpartisan, non-specialty specific public health approach to firearm injury. We've brought together more than 25 different medical and public health organizations, including the APHA, the AMA, the National Medical Association, which is the country's oldest and largest organization of Black American doctors, and others, to try to, again, create this kind of coalition and to create a shared voice that's not based in our kind of institutional politics. As Dr. Deneen mentioned, I helped create and lead the This Is Our Lane movement, which was really only possible because we had done 6 or 7 years of work prior around activating the public health and health community around firearm injury being a health and public health problem. We already had this critical mass of people that when the NRA put out this tweet telling self-important doctors to stay in their lane on gun violence, we all kind of went, there was this group of us that kind of said, are you kidding me? This is our lane too. One of my colleagues created the hashtag This Is Our Lane, and it was off and running. And we had tens of thousands of tweets sharing personal as well as professional stories about firearm injury as it affects the health of both victims, communities, and healthcare providers, and talking about the value of prevention. And that really helped to drive the funding that we saw last summer, finally, from Congress. We also, of course, lead education. This is a workshop that I did in Chicago 2 years ago. That's Congressman Bobby Rush in the middle. We brought together all the trauma centers in Chicago to talk about firearm injury prevention. They'd never talked to each other before about this, despite the fact that Chicago has obviously tremendously high rates of firearm death on the south side of Chicago. They hadn't intersected and created a unified violence intervention program. And so this created a forum for them to start to do that. We also, within Affirm, of course, acknowledge again that this is a personal problem as well. Dr. Tamara ONeill, a fellow emergency physician, was shot and killed in the fall of 2018 by her ex-fiance as she was leaving work at Mercy Hospital on the south side of Chicago. And in her name and in her memory and in the memory of so many Black and brown women who've been shot and killed by their partners, we've actually created a specific research grant to facilitate the development of the academic career of women like Dr. ONeill, with a focus on firearm injury prevention and implementing this public health approach going forwards. Finally, I'm, of course, personally doing a lot of work, as Dr. Deneen mentioned, around the use of technology to try to identify and prevent firearm injury long before it happens. So identifying those early risk factors around physical fights, cyberbullying, and other kind of signs of suicidality. But at the end of the day, we all have to join together. And again, I could give a whole separate talk about kind of how we can create social movements across the US for public health, for kind of sharing accurate facts, and for allowing collaboration across political divides. But this is going to be what will truly make the difference for firearm injury prevention. It's not about any one of us doing this work on our own, but rather about all of us doing it together. So as a recap, for numbers, suicide is more common than homicide. State-specific rates are different, but we see it everywhere, and it's utterly preventable. That public health approach does work, but it needs funding, and we've lacked it for the last 20-odd years. In the clinical setting, there's a lot of preliminary evidence that harm reduction or SBIRT approach can work for high-risk groups, but we need more research. And then outside of the clinical setting, there's a lot of work around creating collaborations with community groups, with law enforcement, with lawyers, with gun owner groups, and with those who are most at risk of firearm injury, whether it is, again, young minority youth who are going to be disproportionately affected by gun homicide, or whether it's with gun owner groups who are disproportionately at risk of suicide. And so today, you guys, as you go away, certainly keep doing the research, work with your healthcare partners to create a standard of care. Please collaborate across the political spectrum. This is not a red or blue issue. And then most of all, I will say, share your stories. If I saw anything from This Is Our Lane, it was the importance of our personal stories about how this affects us and how it affects human lives that really makes a difference. So learn the facts, tell your story, and then take action, whether it's through research or advocacy. I'll stop there. I welcome questions. Thank you. I'm going to end sharing so I can see.
Thank you so much, Dr. Ranney. That was a fantastic talk. Now we're going to start the Q&A. So if anyone has any questions, please do use the raise your hand function I think if you go to the participant area, you can see where you can raise your hand, and I will select you, and also feel free to use the chat. And it looks like we have a hand raised. And Natalie, please go ahead and ask your question.
Hi, how are you? Thank you.
Good. How are you, Natalie?
Good, good. You talked a little bit about technology. I'm actually down in Wilmington, Delaware, which is a bit of a hot spot. And I know that we recently, a few years ago, got this Shotspotter.
Mm-hmm.
I was wondering if that has been at all effective. I guess it's more for crime and not so much suicide, but what are your thoughts on that?
So there has been very little research on the utility of ShotSpotter. There is actually some evidence that it has oversensitivity and may pick up things, that is a car backfiring or fireworks rather than gunshot wounds or kind of gunshots per se. I would also argue that that's an after the fact intervention, right? So you've spotted a gunshot. Terrific. That's too late, right? I think kind of inherent to the public health approach is this idea that we should be detecting things beforehand. The one place that there is potentially some utility to ShotSpotter, although the cost effectiveness is quite doubtful, is in schools. So could it serve as an early warning for school shootings, letting police or kind of other first responders know to go to schools a little more quickly? But again, the cost versus the benefit is doubtful there, but there's ongoing research. I'm so sorry to skip over the technology stuff. Like I said, this wasn't about my own stuff, but I know I've seen Sherry Pagoto in the talk as well, and so I'd be happy to talk more about kind of the work that we're doing around social media and app-based interventions too. But good question about ShotSpotter, and I think it's a great thing to study because honestly, we don't really know. It's one of those like lovely industry products where private industry has come in and said, "Ooh, we have a solution," and there's not a lot of evidence behind it, which we see around a lot of the stuff around firearm injury, unfortunately.
Thank you. And in the chat, we have another question from Dr. Sherry Pagato. She
Hi,
says,
Sherry.
great talk. Can you say more about how you start conversations with patients about gun ownership and the risks?
Yes, thank you. I love that. And I didn't go a lot into it knowing that most of you or some of you are going to be kind of actively seeing patients, some are not. But I think it's a really important topic. So the big thing that I do when I talk about firearm ownership is that I couch it in terms of normalcy. So the same way that I've learned, and all of us have learned, how to ask questions about sexual orientation, how to ask questions about partner violence, how to ask questions about substance use and alcohol and cigarettes in ways that are not threatening or not judgmental, we have to do the same thing about firearm injury. There are some studies ongoing right now about universal screening for access to a firearm. I suspect that those are not going to get accurate data because just as the universal suicide screening, we can talk all day about that and its strengths and weaknesses. You're asking someone about a politically charged issue and they're going to lie because they're not knowing what you're going to do with that data. So the way that I talk about firearm injury is that I contextualize it. So if it's a kid, if I were a pediatrician, I would have that conversation about, tell me how you're storing cleaning products in your house. Tell me about the car seat that you're using for your kid. Do you have a pool? If so, is it fenced on 4 sides? Do you have a gun, or does someone in your house owner have access to a gun? And the reason, if they protest, I say, I'm just asking for the same reasons that I just talked about pools and poisons and car seats, right? And so you contextualize it there that you've already normalized the fact that you're asking about injury. Same thing for suicide. So if I'm taking care of a patient who is acutely suicidal or I'm worried that they might be, right, we have our standard set of screening questions that we ask patients to try to assess risk of kind of the imminence of a suicide attempt or what the best next steps are for them. Have you ever made an attempt before? Do you have a plan? Do you own or have access to lethal means like dangerous medications, knives, or guns? And so again, I contextualize it in that kind of normalizing that I'm not just coming out of the blue and asking you about a gun, but rather I'm asking you because I care about your health and my job as your doctor or your therapist is to try to reduce the risk of you hurting yourself or someone else. There are times where that doesn't work. And just as with our questions about drugs or about sex, we don't always get truthful answers. We don't always get truthful answers about guns. And I don't think we should expect to. But asking sometimes and asking in that right way is better than not asking at all. And based on kind of preliminary evidence, again, so much of this is preliminary at this point, but based on preliminary evidence, that method of asking is more likely to get a truthful response and then to create that therapeutic alliance, which is what we really need in order to reduce the risk of harm. Finally, I caution folks that although, we in medicine and psychology desperately want to fix things immediately, just as we know from motivational interviewing that moving someone from, a 2 to a 4 or moving them from pre-contemplation to contemplation can be a big win. Just getting people to accept and say out loud that firearms can cause injury and that there are sometimes risk factors is in and of itself sometimes a huge win. And so I'm going to give an example there is like with parents, they'll sometimes say, well, yeah, I have a gun, but it's stored somewhere that my kid doesn't have any idea where it is. And I'll say, okay, I say, I'm going to follow up with a question. You know what I'm going to ask, but we know that if it's locked up, behind lock and key, and if the ammunition is stored separately, it decreases the risk. Is your gun stored that way? Or are your guns stored that way? And I'll sometimes kind of normalize that as well, because many people do own more than one firearm. And they'll say, no, it's not locked up, but the kid has no idea where it is. And I'll say, sure, but right, have they ever found their birthday presents? Right? Of course they have. They totally know where your gun is. 75% of kids actually can tell you where their parents' gun is, even if the parent thinks they don't know. And then the other thing they'll say is, well, my kid is safe. I've taken them hunting. They know how to use it safely. They're not depressed. I'm not worried about them. And so then my thing is, well, you might not be worried about them, but, I'm a parent myself. I know my kids have a couple of friends who I don't trust. And your kids probably have a couple of friends that you don't trust either. God forbid that kid puts peer pressure on your kid and your kid lets them take your gun. You don't want to be responsible for that, right? And so it's a way of kind of moving them, and they might go, oh yeah, and then kind of shut me down. Sometimes I don't get that far in the conversation, but at least it's an opening. And then particularly, I'm an ER doc. I don't see people longitudinally for the most part. But for those of you that are therapists or pediatricians or have other relationships with your patients, you may be able to then kind of at the follow-up visit have a little more space for that discussion. Right now, to me, so much of it is just normalizing the discussion, reframing the conversation is just so critical to this work.
Thank you. What a fantastic response.
Thank you.
We have another question in the chat from Dr. Kim Gans.
Hi, Kim. One of my Brown friends. Nice to see you.
And
Brown is in Brown University. Sorry. People go with kids. Yes.
No worries. And she says, hi, I'm wondering about your thoughts on assault weapons bans, other kinds of gun control policies, any evidence that they help? Mm-hmm. And should these be a part of the mix or not are they not worth the political difficulties?
A great question. So there's definitely some evidence behind some policies. There's particularly strong evidence right now. And for those who are interested in more, RAND actually has a great summary of the levels of evidence behind various policies. You'll find that for most policies, the level of evidence is weak at best. There is some evidence that stand your ground laws increase the risk of homicide and suicide. Permit to purchase decreases the risk of homicide and suicide, and that's based on some time series comparisons between two different states that passed those laws at different points. There's also some pretty good evidence that having stricter laws around firearm ownership by folks that have been convicted of domestic violence, and I say domestic violence rather than partner violence just because it's common parlance, but stricter regulations around folks that have been convicted of domestic violence misdemeanors or felonies reduces risk of firearm homicide and maybe firearm suicide as well. And I'm going to actually really emphasize that point around domestic violence, that there are a bunch of studies, and I didn't mention it, I should have, showing not just that being a victim of domestic violence increases your risk of being a victim of firearm injury, but also being a perpetrator is one of the strongest predictors of perpetrating firearm injury against others, right? They go together. You're a person who maybe has impulse control and aggression. As you know, for any of us that kind of working in kind of the psychology fields, those things are going to go together. Maybe you've got some antisocial personality disorder too. And so it's a big predictor of perpetrating future firearm injury, not just against partners, but also against acquaintances or strangers as well. And so those are the policies that have the strongest evidence behind them. Assault weapons bans are an area of tremendous political debate. I co-chaired my state's gun safety working group a couple of years back. It was the one area we could not reach agreement on as a working group, was whether our state should recommend an assault weapon ban or not. The majority of firearm deaths in this country, the vast majority of firearm deaths are with a handgun, not with a long gun. And so if we really want to make an impact on the incidence of gun deaths or gun injuries, it's about getting better control of the folks with those risk factors. That said, of course, those semi-automatic long guns, the things like AR-15s, are what are frequently used for those public mass shootings, which, as I said, it's only about 0.5 to 0.3% of gun deaths in a given year. Those are the things that strike fear in the heart of Americans, understandably. So there's a lot of debate. From my perspective, it's not the thing I'm going to hang my hat on as the way to solve our firearm injury epidemic in the United States. And I personally think there's a lot of better places for me and for many of us to spend our time. That's really kind of a political debate, and I'm not a politician for a reason. Is kind of where I'll leave that. I will say, though, one other policy thing, the extreme risk protection orders, there is growing data that they really do work. They were put in place around, after a guy shot and killed someone else, despite the family calling. And the, oh my goodness, it's a California shooting about a decade ago. And my brain is blanking on which one it was. But it was a young kid. His parents called. He was at college. His parents called and said they were worried. The police went, said they didn't find any evidence of anything. And then he went and committed a public mass shooting. But the evidence behind those extreme risk protection orders is actually that they may be most effective in decreasing gun suicides. Of course, it's also easier to study a decrease in the incidence of gun suicides because they're so much more common. So to achieve statistical significance is going to be a lot simpler from a research perspective. But those can be useful in the right settings. But they have to be used carefully because we don't want to get a reputation for just kind of throwing them. To me, it's a last resort to forcibly take someone's gun temporarily away from them. That's after you've exhausted other options, or you think someone is just so high risk. You can't take the time for other options. I've seen they've been used a few times here in Rhode Island with good effect. And there are a few people that I wish they'd been used for. But in general, that kind of larger harm reduction approach, again, when I think about the gradation, it can be more effective than just going straight to an ERPO. I hope that answers your question.
Wonderful. Thank you so much. We had a comment in the chat that says this talk should be a medical grand round at all hospitals for all employees. And it seems like a lot of people are in agreement, including myself.
I would be happy to. We're actually, so I'll say kind of through Affirm, we're actually working with the Missouri Foundation for Health. We're developing kind of some parts of the talk that I just gave into a larger set of resources in collaboration with a couple of health systems out in Western Missouri, where obviously firearm ownership is common. We also have done some work or are doing work kind of in the Berkshires and in Springfield. Certainly Connecticut, you guys in Hartford you both have kind of the urban or community violence and are surrounded by rural areas that have higher rates of firearm suicide. And so you guys are dealing with both and would be happy to come back and chat with y'all. So thank you.
Great. Thank you so much for joining us today and for giving us a lot to think about.
Thank you. Well, it's a joy to join you all. Thank you. I'm sorry I can't stay to chat afterwards, but would, again, hopefully we'll have a chance to come back and meet in person at some point or have you all out here. Kim, we miss you.
Thank you very much.
Thank you, guys.